myomectomy laparoscopically independently. Oh, sorry. Yeah. Good evening, everyone. So today we will be talking about tips and tricks of doing a laparoscopic myomectomy. This topic is very relevant in this time because we have so many people in our groups who practice fertility and also who are very competent laparoscopic surgeons. So this is a topic where we get so many queries on a day-to-day basis as to like what suture to use, what is the manipulator that we use, what to do if it is a little unusual location of fibroids, multiple fibroids, and all such things. So we have Dr. Jay. I just saw his Instagram reel. I think couple of days back he had posted that he removed some more than like 30 fibroids. I was a little impressed for a change because whenever I have sent him a fibroid or I have kept a case of fibroid uterus for him, it's always been something which I never thought that anybody could do it laparoscopically. Only such cases we keep him just to, I think, test his skills and also how fast he can do it. And always, like usual, he has always aced it. So, be it cervical fibroid, huge ones like 15, 16 centimeters cervical fibroids or multiple fibroids, fibroid touching the liver, all such unusual things, fibroids where we had almost removed almost 70 fibroids in one patient, or like 2 centimeters. So, and he retained that uterus. So that was something which I think we all should learn. Maybe it will take us a lot of time to replicate or even follow the steps that he does. But what I have seen is he makes it look really like, simple, especially when he finishes like the toughest myomectomies in 15, 20 minutes. That is when, like, I start thinking that I need a little more training in such cases. So today he is here to speak. I know he thinks it is like such a simple topic, why we should be discussing this. Everybody knows how to do it. What is the big thing? But even then, I think there are so many finer points which we can all learn and also which we can actually like try and use it in our clinical practice for better outcome of our patients and also to improvise on our skills, which are like practical tips which we may not be able to like find in any of the textbooks, or which will take us a very long time to pick it up by making so many mistakes. Yeah, so I will ask you to speak for 10 minutes and then I will ask the commonly the questions that comes in our mind.
Yeah. So, I would just like to say one thing that we had decided in this masterclass that we won't be showing any videos because we do lap myomectomies whenever I get an opportunity to do. I rarely get to do it, to be very honest with you, because I end up dealing with way more complicated things. But if in case I do get an opportunity, I always try and show it on Instagram Live. And usually, if you see any of our Insta Live sessions for myomectomies, even for multiple fibroids, as Madam said, we will try and finish it in maybe 10 minutes, 12 minutes, 15 minutes, whatever. Okay. I think what is important for us to know is this very important that first thing, please eliminate this nonsensical concept from your head that a particular size of myoma cannot be operated laparoscopically. Okay, that is something which has to be eliminated. It's okay. You may have a deficiency, you're not currently well trained, you can do open surgery. You will easily convince a patient to do an open surgery because 50,000 people will be supporting you. Yeah, cannot be done, cannot be done. But there is nothing like that. Any size of the fibroid. See, what is the maximum size of the fibroid which one can see? 30, 35, 35 centimeters, correct? Why 35 centimeters? Because we are used to measuring everything in the form of gravid uterus, no? You will have 45 centimeters also. What is the problem? But there is no space in the abdomen for all of that. Okay. So there is nothing which states that a particular size of the fibroid cannot be operated laparoscopically. I think there has to be a disclaimer which has to be added in everybody's mind. I cannot operate it. Okay. Otherwise, there will be somebody or the other who will give it laparoscopically and give it to you. That is the first thing. Second, be very clear that when you do laparoscopic myomectomy, you will never see me use vasopressin. I have never used vasopressin. So if you ask Shilpa madam, she'll know that, we don't use vasopressin for anything. We have no vasopressin at all. Correct? No vasopressin for adenomyomectomy, myomectomy, hysterectomy, endometriosis, nothing. And even we operate patients and nobody has a blood loss. Okay, so don't get carried away by that phenomenon, thinking that unless you use vasopressin, the blood loss is going to be very, very much more. There is no such thing. But if you want to use vasopressin, then make sure that you have a good anesthetist with you. Make sure that you have spoken to your patient that, okay, there could be a little bit of cardiac imbalance during the surgery. And you can use diluted vasopressin like how people use. I think 20 micrograms is what people use in 200 ml of saline. And they inject it preferably in the capsule. But tell me one thing, is there any role of injecting it in the capsule? I can inject that same vasopressin in the cervix also, and it will give you the same effect. Okay. So do not think that injecting in the capsule is mandatory, because that is a thing which I've seen people do. They will take 10 minutes to find that capsule with that Veris needle. Okay. Or that spinal needle, whatever people use. But don't do that. Just pick a spot, the cutest spot which is available in that uterus, and just push vasopressin inside. Why do you need to go inside the capsule and inject? Do you think that that little thing will cause that time pass aqua dissection and all these things? All that is not important. See, what is the purpose of vasopressin in the uterus? The purpose of vasopressin is to cause vasoconstriction. Correct? So, what is the best place to inject vasopressin? It is the uterine artery. Correct? No? You should put a needle in the uterine artery and inject vasopressin in that uterine artery. But then why do we inject it in that capsule? There is no such thing. There is no such role. Trust me. Try it in tomorrow's case if you are doing. If you have an anterior wall fibroid, put the vasopressin on the posterior wall. The action of vasopressin is on the uterus. It is on the vasoconstriction of the large vessels. If it vasoconstricts the large vessels, of course, some amount of it is going to get absorbed somewhere or the other. And it is going to cause some or the other cardiac disturbances, isn't it? That is the principle. Otherwise, if you are going in the capsule, that means you have avoided all the blood vessels. Not a drop will enter inside any of the blood vessels or open channels. Then how will vasopressin that get absorbed? By that logic, there should be no complication of vasopressin. Correct? No? So if people are using vasopressin, please remember, you can inject it anywhere. That is another take home point. Third, I have also seen a lot of people doing, uterine artery at origin, putting a clip, putting a knot, which is reversible, irreversible, whatever. Whatever you want to do, basic concept is simple. The amount of blood which is going inside the uterus per minute has to go down drastically, so that when you perform a laparoscopic myomectomy, your bleeding can be avoided or bleeding can be minimized. Okay. So you can put these knots in whichever manner you like. For people who think or who want to make excuses that no, all these types of things are not warranted, not necessary, not to be done, there is no scientific publication. Practically, these types of people should just learn to keep quiet in life, because myomectomy is one of those beautiful cases where you will learn to open the retroperitoneum. And the fear of retroperitoneum which people have, see, that's a different story, that you don't want to upgrade. Okay. And then you want to take only 20,000 rupees per myomectomy, and then people will throw peanuts only at people like you. But in that situation, remember, it is one of the best cases to learn opening of retroperitoneum. It is the best case to learn how to open the uterine at origin. Okay. And if you are able to learn that, no, believe me, your confidence in yourself as a surgeon will go up drastically. Okay. So if in case multiple people, I can give you examples. Two, three of them are very close friends of mine. One is Dr. Sanket Prasad. He has, he does this beautiful shoelace knot at the uterine artery at origin. Very simple technique. If you just follow his videos, just watch it 5 times, the sixth time you will also end up doing it. In fact, Sanket has also invented something called as, for people who are using vasopressin, that vasopressin injection needle, where you will come to know that when the needle is inside the vessel, okay, it will have a blood coming inside that, and you will come to know about that. It's an excellent one. All right, it's an excellent one. So for people who are using vasopressin, you can probably use Sanket's needle. I think it is good. Somebody asked a question, what to do if the fibroid is very large and it is occupying the pelvis? That is the best case to go and cut the uterine. I mean, that is the best case to go and coagulate or ligate the uterine, not cut, sorry. See, what happens in that situation is retroperitoneum will still open, no? Even if the fibroid is large, you go to the retroperitoneum. Retroperitoneum will open in every case. Retroperitoneum opens even when there is a pelvic mass. That means lateral pelvic wall mass. Even in that case, you can open the retroperitoneum. So fibroid is a mobile structure as such. So opening the retroperitoneum is going to be a cakewalk. We open the retroperitoneum in cervical fibroids. You can ask Shilpa madam. We have done, I mean, she told that, she has reserved some of those complicated fibroids for me. So honestly, the only fibroids which I think I have operated at Shilpa Madam's place are all these trans cervical fibroids and, fibroids at little abnormal locations. Apart from that, I think everybody else, Madam is only finishing off. He's not leaving any fibroid for anybody else in Karnataka. Forget anything for me. Okay. So coming to the next important trick, many people question and ask that should they make a transverse incision, or should they make a vertical incision, or should they make a horizontal incision, or whatever incision on the fibroid. See, remember one thing: if you are doing ipsilateral suturing, no, then in ipsilateral suturing for you, suturing a transverse incision is better. Correct? If in case you are a contralateral surgeon, then suturing a vertical is better. If in case you are suturing from the middle port, then anything is better. If you are well versed with suturing, then the manner in which you take the incision will not matter. Believe me. Okay. So do not get carried away by that thing that should I take a transverse incision or should I take a vertical incision? In whichever incision you take, you make sure that the myometrium does not get lost. That means there should be no damage to the myometrium which is happening. Go to the capsule, enucleate the entire capsule. Okay. When it comes to enucleating the capsule, I think I've seen a lot of people using myoma screws. Okay, people put that myoma screw inside that, like that, like that, like that. It goes inside the fibroid and they pull. See, remember, I think myoma screw is used best when you are simply applying traction on the myoma screw. Okay, if you really have to pull, like, tear that fibroid apart, I don't think it is. It indicates that you have taken like a mini lap cesarean section incision. I've seen these ladies take 2 centimeter incision for fan and style. Their index finger will also not go inside, and they will want to take the whole baby out from there. Correct? No, don't do like that when it comes to myomectomy. It is the uterus which you have to reconstruct. If you reconstruct a uterus instead of 5 centimeters, you do 7 centimeters. Who will feel bad? Nobody. Anesthetist will feel good that you sutured correctly. You will feel good that you sutured correctly. Patient will feel good that something nice was done for 20, 30, 40 minutes. And the uterus will not even know if the incision was 5 centimeters or 7 centimeters. So kindly make sure that if the fibroid is, let's say, 5 centimeters, you take a proper 5 to 6 centimeter incision over the capsule. Do not take a tiny incision over the capsule and then try to enucleate that fibroid through that tiny space. I don't think that is justifiable. Take a beautiful incision and just take it out. I personally do not use myoma screw. If you have seen ever me operate, I hardly use the myoma screw. I predominantly use the Alice forceps. I predominantly use the needle holders in order to in order to make sure that the fibroid comes out. I never use myoma screw. I don't like it, to be honest with you. I don't even use myoma screw for manipulation in my hysterectomies, or in fact, I don't do any manipulation. So uh, if in case you ever see any of my procedures, there is hardly any manipulation, correct? So I don't do it, but if people are comfortable doing it, as I told you, it is an individual choice. You can do whatever you want to do, right? Now coming to the suturing part of it. See, I use barb sutures and I have used barb sutures extensively. I mean, on an average, we consume close to 1,500 sutures every year. Okay. And this has been going on since the past 5 years. So, and this is company data. So you can verify it from Statafix. And now you can also go for the inquisitive ones. You can go and verify it from Covidian. So they will give you the data for this. All right. Now remember one thing. Uh, every barb suture is good. Okay, there is no problem as far as using a particular type of barb suture. There's nothing that let's say suture A is better than suture B. There is no such thing. Okay, it is how you suture which makes the difference. So when it comes to how you suture, I know people will talk that I use baseball, I use this, I use that. Very good. Just remember one principle of suturing: close the cavity. Bus. The cavity has to be obliterated with minimal to no hematoma formation. That means if the cavity has been closed in single layer, double layer, triple layer, how many layers you want to take, as long as you have closed the cavity, there is no problem. Okay? One more thing I want to add here. People who get shit scared about opening the endometrium. Okay. Oh, I opened the endometrium. Now what will happen? Nothing will happen. You open the endometrium very routinely when you are doing hysteroscopic myomectomy. Next time you do a hysteroscopic myomectomy, please keep your eyes open. You will realize that you've cut the endometrium and taken the capsule from within that myometrium. Correct? So the cavity is open. The cavity will heal with lateral epithelialization. You should not be worried. Okay, there is nothing that you should close the cavity separately with some vicryl, and then you should use above that closure with some another layer. Don't go by these types of things. All these types of things are not required. Okay. One more thing, which I think it is important to address because people really find it so cute. Okay. I really want to know from each and everyone. We have what, 237 people in the audience right now. So I really want to know from everyone. Raise your hands. Okay. Genuinely, no cheating with me. How many of you actually use an in-bag morcellation for each and every laparoscopic myomectomy that you do? Bindas, raise your hand. Nobody is judging you. The people who are judging are simply attending conferences and nobody is attending those conferences. So here, please, bindas, raise your hands. Because I know one thing for sure. Okay, one thing for sure. If you are honest, no, by mistake, if you have any honesty remaining inside you, you will accept this. That, let's say if you are doing 100 myomectomies in a month, okay, if somebody is doing, the need to use that more safe bag or an in-bag morcellation is in less than two cases. Okay. The reason I'll tell you, I'll justify. It's not that I don't want to justify, I'll justify now. If you are worried about sarcoma, you should do open surgery. Don't be a donkey and do laparoscopic surgery in that situation. Second, if in case you are one of those guys who feels that I want to avoid spillage, why are you morcellating? Take a beautiful T-shaped colpotomy. We have published it now. So for the people who want to learn it, it's a published literature. Okay, it's going to come in Trocar. Take a beautiful colpotomy and remove the fibroid out intact, no? If you are worried about morcellation. So the question is, in-bag morcellation can, at its very best, only prevent peritoneal spillage of fibroid contents. It will not reduce or prevent the upstaging of sarcoma. 100% not. If you've made an incision on the uterus and there is circulation of insufflation gas, that means carbon dioxide insufflation in the peritoneum, 100% with your first incision, you have upstaged the disease because CO2 will make sure that the cells which are lying on that tissue will get circulated through the peritoneum and you have converted that sarcoma from stage 1 to stage 3C. Okay. So I have trained 3 years in gynec-oncology. So please do not try to scare me with any of these fancy principles of Morsafe bag. So I don't use it. I don't think nobody can take me to the court for using it. I will win every case against everyone who wants to try doing all this shit with me. But remember one thing, no great role of using Morsafe or in-bag morcellation in every case. Okay, if you have 20 fibroids, you want to use morcellation, patient has given you the consent for power morcellation. Okay, that is when you use a Morsafe bag when there are multiple fibroids. What I do, I will tell you. If there are 40 fibroids, I will make a T colpotomy. That means I will go to the posterior vagina. I will make a straight linear T colpotomy. How many kgs children Shilpa madam takes out from the vagina in normal delivery? It is 2.5 kg is the normal baby weight in India. Understanding? I think these days it must have become 2.7 considering all of us becoming obese. But if a 2.5 kg baby can come out, you think 200, 500, 700 gram fibroid will not come out through that same vagina? You just have to do a proper T colpotomy and that thing will, you can cut it into multiple pieces and it will come out. So I don't think that is a thing because I don't use so much morcellation any which ways. I have a 2-page consent for morcellation. And if the patient signs that consent, only then that power morcellator goes inside. Otherwise, we do a T colpotomy and everything comes out through that. This is my belief. Okay, this is what has helped me the most. This is what has helped me in my practice, whatever little I have. One more thing, which I want to state about fibroids when you're doing myomectomy, and this is a very important part of my consent. So I'm stating it. If there is a solitary fibroid or a dual fibroid, basically less than five fibroids, then the risk of recurrence is very less than 1%. If the fibroids are between 5 to 15, the risk of recurrence is 10%. If the total fibroids are more than 15, then the risk of recurrence is 20%. This is there written down in my consent. Every patient, see, majority of the patients whom I operate for myomectomy are 25, 40, 30, 60 fibroids and above. Okay. And everybody signs that consent. Nothing happens. Everybody signs that consent. We do redos also for that. I also want to address, because I'm given this opportunity, the thing of doing microwave ablation for fibroids. So, in fact, just today I was speaking to Xiaoming, who does a lot of microwave ablation for fibroids. And I'll tell you one thing: the cost of a single microwave ablation probe, the good ones, is 1,55,000 rupees. The cost of doing a laparoscopic myomectomy in a tier 1, tier 2, and a tier 3 city in India is less than 80,000 rupees. GIPSA package for a single lap myomectomy is 75,000 rupees. So just in case you are telling me now that you want to do a trans vaginal microwave ablation of fibroids, I challenge you, show me, do 10 cases a month and show me. Okay, it's not going to happen in anybody's practice. So don't fall for any of these fancy tricks. I know a lot of patients have joined. You must have got bored listening to 20 minutes of this, but I want to tell you one thing. To all the stupid patients who think they are great by researching on ChatGPT and going for uterine artery embolization, believe me, you are the dumbest audience India has ever produced. Because uterine artery embolization is a reserve therapy in fibroids. It is to be used if in case you do not have surgical fitness. Uterine artery embolization does not cure you of the fibroids, nor does it do anything to the fibroids. The only thing it does is it cures you out of having a child. Majority of you will be left permanently infertile. Okay. So do not fall for these fancy things thinking that, oh, it is so cute and non-surgical. You idiots, it's a proper surgical thing. You are taking surgical consent and it is as expensive as a surgery. So I personally do not want you girls to fall prey for any of the marketing practices which happens around uterine artery embolization. Of course, should you be destined and should your destiny be so bad that you will end up with one of these procedures, you will end up with it any which ways. Okay. So with this, I conclude. I'm sure I've missed out on some points, and Shilpa madam will ask those questions, and I'll be happy to answer those questions.
Okay, so what happens in these multiple fibroids? Do you take just one incision and go on digging and make a
Yeah, so
tunnel?
you've seen that, right, ma'am? So what I do is from the cervix, right, anterior cervix, I'll push the bladder down, and then 2 centimeters above the cervix to 2 centimeters posterior cervix. I'll take a straight incision, open the uterus like a flower into two
Mm,
things. And then wherever the fibroids are, we will just dig and we'll remove. I want to tell one thing, ma'am. You have a great ultrasound machine in your OT. And I think I have one, Arti madam has one. And I would really request people who are doing multiple fibroids to keep an intraoperative ultrasound, transvaginal intraoperative ultrasound, so that you don't miss out on the small fibroids.
yeah. So tell me this. See, you were talking about recurrence. I think it's very important, and we have done so many. I think operated case before who come with fibroid again, like recurrence. So in
Yeah,
such situations, I mean, what is your counseling? I have heard you like where we had a patient who had previously 3 times operated for myomectomy, and again she had 10 fibroids now.
yeah.
So
No, I
I
see. I am one of those guys, madam. I really will think of that patient first. You've always seen me doing that. So I normally go and tell them for a hysterectomy.
Yeah, yeah. So in your, I mean, I have seen that we have gotten like, referrals where patients have done even open hysterectomy and ended up with Asherman syndrome because there were like so many submucous fibroids which they had to like remove. So in
Yeah.
such cases, like I have seen 2 cases. So in such cases, what is your like, advice how to prevent this Asherman syndrome? So basal layer to basal layer, how does it get adherent and what is the precaution that we need to take?
Uh, Frankly, nothing much will be one can do. If there is too much damage to the endometrium, there can be Asherman syndrome. There is no question in that fact. You need
Mm,
to preserve that little bit of endometrium at some places or at majority of the places to make sure that there is no such thing in the future.
mm,
But
mm,
otherwise, if you damage too much of the endometrium and if your suture passes through that endometrium, correct, then the possibility of having intrauterine adhesions is very high.
mm. Okay, what about like, this suturing that you do? So you take a 45 centimeter number one Stratafix and start suturing. And then you see that like, you will need another suture because the uterus is cut wide open. So
Yeah.
do you suture these two? Like, do you tie a knot between these two?
I do, but it is not recommended to tie. I tie,
Mhm.
it is not a recommendation. I tie because I have seen so many cases which have been operated by people where the knots have given way and the ilium has gone inside that suture site and it has got necrosed, infected. That is the things which get referred to me. So I have this habit of tying, but I don't think it is recommended.
Mm. So, in cases where the fibroids are associated with endometriosis, and we are doing combined surgery of these things, and the patient is desirous of fertility, so do you recommend doing like, egg pickup and then do the surgery and then come back and operate on all this? Or do you think like, the
That would be a
vascularity?
call dependent upon the size of the endometrioma and the deep endometriosis which is present. No?
Yeah,
So
yeah. So, in a solitary fibroid and patient desirous of fertility, so do you advise first myomectomy and then do the pickup, then do the myomectomy?
see, if all other reports are fine, no, then if you remove that fibroid, she will conceive naturally only.
Yeah, yeah, correct.
Honestly, see, we
Yeah,
have seen so many patients in whom 12 centimeter fibroid is there. Some
it's okay.
person has
Calm
done
down.
IVF with embryo transfer, okay, and you remove that 12 centimeter fibroid, tubes is open, everything is done in 4 months. Those people will conceive.
Yeah,
So
yeah.
I'm sure everybody has seen this, but
This.
it's very surprising.
So, for all cases, like, I mean, do you suggest morcellation or do you say like do a mini lap incision and take off the
No,
fibroids if
no,
it is?
just do vertical colpotomy. Why should you do mini lap? Just do a vertical colpotomy. Remove that fibroid, na. Full thing will come from there only.
Yeah. So thank you very much. I think it was a wonderful session, but it will not get over so soon. I think we need one whole hour of next session of Project Pelvis. We should do a workshop on lap myomectomies,
Yeah,
if
maybe. I
possible.
just wanted to answer two, three more questions which had come in the chat box. See, after you remove myomas, you can start fertility treatment in 2 to 3 months because you are going to be waiting for myometrial healing. Myometrial healing takes 2 weeks. After that, the resolution of the sutures which you have taken from inside is going to take another 4 weeks. That's why you have to wait for 6 weeks because the resolution, the hydrolysis time of the suture material is close to 90 days. That's why we say 3 to 4 months. Understanding? But you will have people now, mystoscopic myomectomy is done and patient has conceived in 2 months. You don't go and tell those patients to do MTP, no? The pregnancy continues nicely, nothing happens as such. But then, if in case you want to be super safe, uh, you can, probably try and do it like this. Yeah. How to manage the remaining part of fibroid in submucosal fibroid? Are, why should there be anything remaining in submucosal fibroid? Yeah, it is already submucous. Just remove everything. No, you should not keep 50-50 inside. Okay. The role of luprite does not exist in fibroids. I mean, it does exist, provided you want to waste patients' money. But then for an otherwise normal situation, there is no role of this. Yeah, you can see video of vertical colpotomy. We have shown it 100 times on Instagram. So you can see it on Instagram, you can see it on Facebook, just in case any of those videos are there. Multiple fibroids in unmarried girl, best procedure is to remove the fibroids. Now, whichever manner you are comfortable with removing, if you think you are comfortable removing open surgery, do open. If you think you are comfortable removing vaginally, remove. But just remove. Do not just keep those fibroids inside as a showpiece museum for that patient. Okay. Role of fibroids removal during cesarean section. I think, see, if the fibroid is larger than 6 to 7 centimeters, lower segment, that uterus is also very big because of that fibroid, then remove. But then 2 to 3 centimeters of the small fibroids will undergo remodeling in the time by the time that uterus comes back to normal size, no? And you may never have to remove those small fibroids. So just keep that in mind. Yeah, definitely. I use histoscopic morcellator. In fact, I was one of the first guys, not the histoscopic morcellator, True Clear. I was the guy who launched Morcelion, which is the Indian-made morcellator, histoscopic morcellator, and uh, and it was amazing. I mean, it works amazing. So we use a lot of it, and we do a lot of histoscopic myomectomies based on that for the people who can afford that. And I think it's a great thing. So I hope I have answered most of the questions. The rest of the questions you can post them on our WhatsApp, and we will try to answer them for you. Yeah.
Thank you. Bye.
Bye.